Well, thank you everyone for joining and folks who are watching this later. This is a sort of historic book club because it's the 30th book club that we've done for this Bouncebacks Critical Care book. And interestingly, that is the last chapter. So we have made it from 2021. I will say along the way, there have been a couple times that I've thought to myself, man, what did we get ourselves into this 4-year commitment? And in the end, though, it's been absolutely worth it. I tell you, I have learned so much from the amazing panelists that we've had on. And I just want to take an opportunity to thank and introduce our panelists here. And there's not really tons of introduction I really need to do, but Matt DeLaney is a good friend from University of Alabama, emergency medicine. And Dietrich, we have known each other for like 35 years. Is that possible, right? Because we're only 37 years old each, right?
Correct.
But Anne, I had met at Nationwide Children's here in Columbus, and now is professor of pediatrics and EM down at University of South Carolina. Amal Mattu, professor of emergency medicine at University of Maryland, and Willie O'Neal, who had been a resident at Adena Regional Medical Center, where I work, and is now a sports medicine fellow. You will see that is very important for the case that we're about to talk about today. So thank you everyone so much for coming. I'm going to start sharing our screen here because this case that we're talking about here today is an important case. It's a 12-year-old girl who presented with lightheadedness initially, and then we'll sort of see what happened to her along the way. So folks, you will get 1 hour of category 1 CME credit, and that is free credit. There's no obligation for that. Beyond that, none of our panelists here have anything to disclose. There is no there are no bits of financial remuneration we have for sharing medical education about evaluating 12-year-olds who have lightheadedness. So maybe there should be. But this is the QR code here. We'll flash that again towards the end of our program. And here are our panelists again for folks who have not seen that. As we know, this is all available later. It will be available tomorrow on the website, EM, like emergency medicine, so embouncebacks.com. And our next book club is going to be on February 2nd. This will be a vertigo case. And because we have finished this book, we're going to pick different chapters from the other books. And we will have none other than Jonathan Edlow, who is one of the really national experts on evaluation of vertigo. And he'll be one of our panelists. There'll be other ones also. So I'm going to start off by telling you a story, because all of our cases, all of our patients are actually stories. And this is a story of a 12-year-old girl whose name is Brittany. She's healthy, she's active, and she enjoys hanging out with her older sisters, playing with friends. She's competitive. She played soccer in the fall, and in the spring, she runs track, trying to emulate her 16-year-old sister, who has been to districts twice in the 400-meter dash. On July 12th, her team was competing in a invitational. It was a hot day, and she decided, because she didn't want to cramp up, she really had a minimal amount of water and a minimal amount of food. And she started running her event, but towards the end, she just didn't quite feel herself. And 20 meters from the finish line, she ended up falling, crashing into a hurdle. But the competitor that she is, Brittany, got up slowly and walked across the finish line. So what you're going to see here is the actual documentation from this initial visit. Now, you might think to yourself, wow, this is sort of sparse, but this is actually the documentation that happened. Now, we took out the nurse's notes, etc., that weren't relevant, not relevant ones. And so what we're going to do is actually go through this. And I just want to share a little bit. I'm going to pull this back a little bit so you're not distracted, because what I have to say is so important. Is I've been doing these residency lectures. They're called documentation disasters. And I started them probably similar in some ways, but I'm sort of evolving a little bit. And I sort of feel like this question that I'm about to ask is a way that might be the most engaging way to ask the question is, do you feel lucky? And the reason I asked that question, and if you just think about chest pain, so not about Brittany, but just about chest pain, the data will show, and we have a study that has been submitted that we just finished to academic emergency medicine looking at this very question. But if you think of the big three in chest pain, acute coronary syndrome, so ACS, PE, and dissection, well, the numbers, and you round them up, approximately 1 in 10 of our chest pain patients in the ED is ACS. Maybe it's 1 in 20 even, according to a study by Farinoff. 1 in 100 is PE, And based on a study by Alter, 1 in 980, or basically 1 in 1,000, is dissection. So here's my question, and why I'm asking, how lucky do you feel? Because if you don't even ask one single question for PE or dissection, you're still usually right 99% of the time, or even 99.9% of the time. And that might be okay when you're playing 5-card Hold'em poker. It might even be okay for any one single patient that you're seeing. But if you think of us in the course of our career, 150 to 200,000 patients, if you think of the number of chest pain patients, maybe 6%. So say 10,000 patients we see during the course of our careers with chest pain. Well, when you think about it, being mostly right, even 99.9%, is not adequate. So in the context of that, let's get back to our case with Brittany. This is the documentation that we have, and I'm just going to summarize it here briefly. Chief complaint from the nurse, dizziness after running a race in the heat. So they're already sort of telling us the diagnosis, i.e. she should have drank more. I get it. The farmers, it's always too much rain, too little rain. It's never the exact amount. The patients always come to the ED too early or too late. I get it. However, the physician documents she presented with dizziness, not feeling well at end of race. She has no headache, no vomiting, but did feel nauseated. So we're going to talk about this documentation in just a second here. To me, spoiler alert, it feels a little bit like a restatement of the chief complaint. Her past history is essentially negative. Her heart rate is pretty high here. Blood pressure may be normal for a 12-year-old girl, and her physical exam, pretty cursory. However, it is negative, at least as the way it's documented. Their decision about an hour and a half after she reached was to give oral fluids because she appeared dehydrated. They diagnosed her with dehydration and send her home. So in the context of that, what I'd like to start with here, and give me just half a second here. I just want to make sure we got everything exactly correct. Yes. Okay, that's why I put that highlighted there. I want to start with Amal, and I sort of already know the answer to the question. Amal, do you think this was a pretty adequate documentation and evaluation of her dizziness? Would you be pleased with one of your residents or students if they documented this and presented a case in this way?
Definitely not, Mike.
No.
That was a softball that you threw to me that just hit out of the park. You know, I can't really comment much on the history because there is none. There's really no history there. There's minimal. It really looks more like a triage note, or maybe a docket triage is just writing a couple lines and then it's going to send the patient out for a bunch of orders, and then a more thorough history of present illness and et cetera will be done by someone else. But dizziness is one of those complaints that I'm sure that all of us kind of shudder when we hear it or see it on the chart, because it means so many different things to different patients. It could mean signs of a posterior circulation stroke. It could be peripheral dizziness like BPV or labyrinthitis. It could be that they're using the term dizziness to describe malaise. It could be that they're describing pre-syncope. It could be anxiety or something psychiatric. And the only way to clarify what type of workup the patient's going to need is to do a good history and try to parse through those different things. And you mentioned Jonathan Edlow is going to be talking about vertigo. He's the master of dizzy, Dr. Dizzy, we call him. But you've got to do a good history of present illness to figure out what exactly she means by dizzy. Now, I'll say she's a young person. She just came out of this race and she didn't eat and it's hot outside. And so maybe you might presume that this is pre-syncope. But even then, there's some deadly causes of syncope and pre-syncope that you need to ask about that may be dehydration, but it could be something dangerous. And this history is, if there's a bad outcome and this were to go to litigation, I really don't think that this is defensible at all, the way it's written.
So let me call you out a little bit with the follow-up question. And Willie, in just a second, is going to talk about a differential here. But what are some questions that you'd want to ask regarding her dizziness? Because, you being usually right, we know is not good enough. But again, if you were betting $5, you'd bet it's because she just got dehydrated in the heat. But what are the questions you'd want to know, and what are the questions you'd ask specifically to Brittany?
Well, I guess I'll preface this by saying that, looking for dangerous diagnoses is a needle in a haystack. It's like low back pain. 99% of low back pains are nothing. But the entire purpose of training in emergency medicine or emergency care is to pick out the needle in the haystack. That's the whole purpose of the training that we do. And that's what we have to do with this history. So the questions that I would want to know, first of all, I try to figure out what exactly do you mean by dizzy? Was it a spinning sensation? Was it brought on by a certain activity or movement? Does it completely resolve when you absolutely sit still? Or is it brought on by head turning and so on? Again, I'm going to presume that this is more of a pre-syncope, just based on the history. It's not an assumption that normally I would make, but for the sake of time, we'll make that assumption. But even then, there's some deadly causes of pre-syncope that can occur in a young woman. Is it possible that she's been bleeding from somewhere, heavy periods? Is it possible that she's got an ectopic pregnancy and it ruptured? Is it possible that she's had recent hematemesis or bleeding from her bowels? None of these questions have been asked. And also, is it possible that she has some type of cardiac problem associated with the exertion? Could this be hypertrophic cardiomyopathy or rheumatogenic cardiomyopathy? So these are questions that are needles in the haystack, but the whole purpose of the HPI, which could potentially take 30 seconds, is to pick out those needles that could potentially kill her. And if you don't take that time and use a little bit of brain power to think about that differential, then maybe that 1 in 100 patient is going to die. But we've all been there. Those are 1 in 100 patients that we never ever forget about, and we lose sleep about at night. And I'd rather take the 30 seconds and ask those questions than lose sleep at night.
Yeah, wouldn't you feel terrible if you had simply not asked the question last menstrual period? I'm just for example,
Right.
and it was 8 weeks ago, and turned out that this was a ruptured ectopic pregnancy, right? So, I mean, it's a simple question, and I've said many times in the past, sorry to be broken record alert, but a good history is free, and a poor history can be very expensive. Of the over 140 medical legal cases I've done, the biggest fallout is a poor history of past illness. So, Willie, we've been listening to all of us talk. What are some of the things that we'd want to consider on a differential? And sometimes that differential can then backdoor us into which questions we would ask, because we're going to ask questions with the consideration of the fact that those things might have been occurring.
Right. I think kind of given the history of what the patient is stating, and the parent that brought him in kind of, had a event earlier in the day. It was hot, didn't really drink much, didn't eat much. I think kind of the big one and this is what the physician assumed, was dehydration. We also want to consider hypoglycemia. And then in an athlete kind of that has done a prolonged exertion event, such as this athlete, exertional hyponatremia, you might want to consider. And then kind of the other things that that we talked about are like cardiogenic causes, either arrhythmia or structural causes such as hypertrophic cardiomyopathy. And then the other things you want to consider are anemia. I mean, this is a adolescent girl, may have recently or started her menstrual cycle, could be bleeding heavily and doesn't know that she's bleeding heavily. And she could have anemia, and that could be a reason why she's, pre-syncopal.
And thank you very much. And, again, thinking about that differential that you came up with, Willie, as well as some of the stuff that Amal talked about, well, asking those questions, again, hoping not to just get lucky. So, Anne, this is probably a short question for you now, because we have some longer questions for you later. And I'm going to give you a softball also, like I did to Amal. Any vital sign abnormalities here that you're concerned about?
Oh yeah, absolutely. The pulse is
Oh, sorry. That was to Anne. So sorry.
Oh, sorry. My bad.
That's okay. Definitely. And after getting those vital signs and seeing a pulse of 153 in a 12-year-old, you've got to be concerned. And if you haven't gotten that history, it's time you go back into the room and get a better history, because that's very, very tachycardic. And as I remember from one of your first lectures, Mike, what did you say? Vital signs are vital? And having abnormal vital signs on a chart are kind of a gift from heaven, because sometimes you might not get them. But in this case, you really are getting a 153 pulse rate. And even though children will be tachycardic when they come in from fevers or other things, we have a picture with the normal vital signs. If you're not sure, or if you've got a junior faculty member with you, they should go back and look at the card and look and see what would be the normal range, because this is clearly very excessive. Blood pressure is okay at 108/70. For a healthy, athletic 12-year-old, you'll sometimes see that, but you do have to be a little concerned, because most of my patients, I only do peds, are hypertensive when they come to the emergency department just out of the joy of coming to visit us.
Yeah, so here's that normal pediatric vital sign chart. And, look, you got 153. Hey, check it again. If it's 200, you're really concerned. If it's down to 100, you're hopefully reassured, right? And so that's the nice thing, is there's no rush, right? You don't have to get that kid out of there. You can have this checked again. I mean, it was probably 153 when she finished the race. 153 after she's probably spent a little bit of time in the waiting room and is now sitting in the ED cart. Boy, that's definitely a very, very, very high heart rate. So I'm going to put the chart back up here. Matt DeLaney, bring this all together for us here. I asked Amal the same way, and all of us work with residents here, and your resident brings this whole chart to you now and says the patient's dehydrated. You can tell she's dry. We gave her some fluid. She's feeling better. I'm going to send her home. What do you say to that resident, Matt?
I kind of have two thoughts. Is this an adequate evaluation? I would say this chart is not adequate. I agree with Amal. I've tried to defend cases like this. You really can't. So I'd say the documentation is poor and bordering on indefensible. Now, we all know good physicians that take great care of folks who are just bad charters. And we try to tell them, just write us a little bit of your thought process. You're very smart. They don't do it. So I think that unless there's some tremendous amount of thought that's gone into this, they just didn't want to write down. I don't think this is an adequate evaluation. I think it gives us very few details. I don't get any evidence of thought processes at all. This question of, should a neuro exam have been done? I think I would step it back. I'm not convinced an exam was done. Regular rate is documented. They're at 153. So I would say this. I would not go to trial and say that this is an adequate evaluation of this patient if this is all we have, this documentation.
So one of the cases that I'm familiar with recently, there was a documentation that was done. And as it turns out, this was the doctor's macro or smart phrase, however you want to put it. And it was, obviously not true. And I won't say that anything more harsh than that, because I'm sure all of us have at some point put pupils equally round and reactive to light when the patient has a prosthetic eye, or about the pulses. And look, that's not great, right? And I get it that there are poor documenters. But one thing that almost said it, our first, it was actually the second of the MRAP risk management discussions that we had just back in April of this year, is think about how this patient might bounce back in a day or two. We're going to see in this case, it was a lot sooner. And just account for that, maybe even just in your medical decision making, right? Say, here's why I don't think those things are going on. I mean, our chart is a story. It's an argument. And just like you're saying, Matt, the argument in this case wasn't made well. So we're going to move forward here and find out what happened to this patient, because she did get discharged, and 4 hours later, she did return. And here's the documentation when she came back. 12-year-old female with syncope now. She was in the hot weather all day sweating, drank 1 sports drink and 2 water bottles, which actually doesn't really sound like that little to me. It sounds like that might be okay. Has not eaten. She fell once. No history of head trauma or neck trauma. No vomiting or fever. No headache. Okay. So her past history is pretty similar. They do document now that her last menstrual period was 2 weeks ago. Now, and her heart rate's not 153, but 165. But also her blood pressure is not, as it was previously, 108 systolic, but now is 68 systolic. So this is a little bit of lights and or four-alarm fire type of situation. So this bounce back critical care book of the 4 bounce back books really uniquely focuses on the return visit. So that's where we're going to spend the rest of our time here. We did focus a little bit on that initial visit because I thought there were some good teaching points. So here's her exam: cardiovascular, pulmonary, her back exam, neuro exam. Color is gray, another concerning finding when you have a low blood pressure. So let's sort of get to decision point number 1. And I want to get Amal back in the mix here. So the patient came back with syncope. Now, let's just move a little bit of a branch point away from her specifically, because literally, if I think of the best lecture that I've ever heard in my life, and I will say that I emulate you when I give my own syncope lecture, and I do give you credit, is your lecture on syncope. It's just so logical, and it is just something that really has enabled me to, again, without any testing beyond just an EKG, send so many syncope now normal patients home. So will you give us, like, say, 4 minutes of a summary of how you evaluate adults with syncope? And then, Anne, I'm going to ask you to summarize how you evaluate kids with syncope.
Sure. Well, thanks, Mike. That was really nice. I love
True,
syncope.
it's true.
I love syncope. It's one of my absolute favorite chief complaints to take care of, and it's because it is one of those conditions where the eventual diagnosis can be something completely benign, or it can be rapidly fatal, and the entire workup is one of those rare conditions where the entire workup can really be based on a good history and physical exam, which, like you said before, it costs nothing, and it takes a lot less time than the automatic shotgun CBC, Chem 50, CAT scan, and everything, SED rate, CRP, throw in an RPR, what the heck, all of these things that get routinely just checked off, and you can whittle that down to just a good 5 minutes if you're willing to do that. The only test that should probably routinely be done is an EKG. And that's one test that should be done in every syncope, in my opinion, because it can give you information that the history and physical can't. But every other test can be predicted by the history and physical exam. So you want to do a good history, first of all. Is the patient having any bleeding from above or below, vaginal bleeding, rectal bleeding, any hematemesis? If yes, get a CBC. Is the patient looking pale? Do they have pallor? Get a CBC. Does the patient have bruising? Get a CBC looking for platelets. If they're on anticoagulants, you check an INR. But if they don't have any of the above, then there's no utility to the CBC. And evidence-based medicine and randomized studies have confirmed that. Do you need to get chemistries on a patient? If they've been having nausea, vomiting, diarrhea, if they're on diuretics or they're diabetic, kidney patient, yeah, get chemistries. But if they don't have anything suggesting an electrolyte abnormality on a good history of physical, you don't need electrolytes. Again, confirmed with studies. Do they have a normal exam? Now you move on to the exam. If they've got no murmur and they're on a monitor and not throwing PVCs, there's no utility to routine Holter monitoring. If they have a rock solid normal neuro exam and no recent head trauma, then there's no utility to routine CAT scan of the head. So it's wonderful because a good history and physical will predict every test that you need. Now in this patient, there's a lot of tests that are necessary based on this history, right? I mean, she's crazy tachycardic and she's hypotensive. So that right off the bat, you need to start thinking about potential blood loss. And she hasn't continued to be running, so there's probably not just further dehydration. And you've got to do a good physical exam. There's no abdominal exam. And in my career, the biggest deadly misses that I've encountered are in the belly. I believe the abdomen is the true black box, not the brain, not neuro, but the abdomen. And so the one part of the exam that I always do with every patient that gets signed out to me is the belly exam. I don't even care about talking to the patient. I'll go in, push on the belly, and then walk out. I'm just kidding. I do talk to them, but it's the belly that scares me more than anything. And then the neuro exam, the cardiac exam also, you want to definitely check for murmurs and rubs, which it appears was done here. And then the neuro exam is really, really critical as well. So the 3 key parts of the exam: the belly, the heart, and the neuro exam. And, when somebody writes GCS 15 non-focal, to me, that's kind of like the old WNL, which means we never looked, right? It's just, it might be a template that somebody checked off. So I'm really skeptical when I see that. But again, just the vital signs alone will predict that this patient needs a further workup. And also, again, I'm a big fan of the EKG. I think any young person, especially with syncope, exertional stuff, that they've got to get an EKG also. And I think that's how I approach syncope.
Perfect. And you mentioned that history and physical, because I'm guessing all of us, when we went for our medical school interview, said we wanted to help people. None of us said we love consulting other doctors who are smarter than us, right? And this is the quintessential time that we can care for our own patients. We do a good history, do good physical, EKG, patient goes home, right? That's the bedside evaluation that we went into medicine for, not because we love like consulting other doctors, right? Or ordering tons of tests that are unnecessary. So, and I had said we were going to talk about this. I'm going to ask Willie about different parts of the H&P for pediatric syncope, but I just have you, we'll jump ahead a tiny little bit. Just think about a differential for pediatric syncope, because it's very different, or it can be different, I should say, than adult syncope. And I'm going to put the list up here if that's all right.
No, that's great. So things that you would want to think about in pediatrics is going to be cardiac. I agree with Amal. We would, of course, do an ECG, although in pediatrics, it's just statistically much less likely. And this patient kind of had a sudden onset. She doesn't really have a history of congenital heart disease. She doesn't really, it's been a continual process since the race. So she doesn't really give you, when I exert myself, it's something there. Now, could this be a myocarditis that's gone into congestive heart failure? Yes, but I wouldn't have expected her to be able to go out and run a race and make it to the emergency department, but that could still be on your list. Seizure, for the first one small thing they did document was she had no seizure-like activity. She doesn't have a history of a seizure disorder. The story is not good for a seizure, but that's something else that you'd want to be thinking about whenever we get a history, usually in our younger children, because they can't give us a history from what exactly happened. Heat-related is going to be on the list, but boy, this story is kind of falling apart for a heat related. She didn't have a high temperature when she first came in. She really, I have to agree with you. She drank quite a bit compared to what I would expect. I mean, maybe if she had an underlying eating disorder and hadn't really been taking care of herself and then went out and ran a race to try and lose more weight, but we don't get a story like that. And it looks like she pretty well drank, at least during the first period of time. Dehydration, hypovolemia. We do see a lot of kids that sometimes, especially teenage girls, somebody, I think Willie might have hinted towards this, they can't tell you what their periods are like. They don't know what's normal and what's abnormal, especially girls that have first started their periods. They don't know if it's normal to go through 6 pads a day or 8 pads a day or 20 pads a day. So that is one history that, 2 weeks ago was her last period. Did she bleed continually for 17 days? Because that would potentially have been aggravated today with her race, although this is a pretty quick process that's ensued today. I'm terrified of ectopic pregnancy. We had one patient that ended up dying from a ruptured ectopic pregnancy. So I'm pretty fast to say to parents, listen, this is just a yes/no question. It's a yes/no test, but we can't afford to miss it, because the earlier you get them taken care of, the safer it's going to be. And I believe there were 1 or 2 studies that came out that suggested syncope actually was a pretty common presentation for 16, 17, 18-year-olds with ectopic pregnancies. We got a terrible history for viral illnesses for the myocarditis, or could she have had mono and then had something happen where her spleen's enlarged? Somehow she's gotten some bleeding into her abdomen. I agree with Amal. One of the places that I always go back in and check, especially in the teenage girls, is the abdomen, because sometimes they have a hard time telling us they've been sexually assaulted. They have a hard time telling us they've been abused. But sometimes when you're doing that exam, especially if you do it a little bit more privately and personally, you can get some further information that might lead you to suspect abdominal trauma, rape, or something that might predispose them to either pregnancy or some type of internal injury. But we all know with EBV, you can get an enlarged spleen, and that might predispose you also there. Abuse, thank goodness she's older and can talk to us. So if we ask the right questions, we could probably get the information there. For the little kids, we've all seen the 1-year-old that shows up unresponsive, tachycardic, and you sometimes don't get a very good history with it that's been multiply abused. And a lot of our studies are showing now for peds, abdominal abuse is winning now because they've recognized that hitting the head is a little too obvious. And so, Amal, I'll take your thing. One of the places I look, especially my under 2-year-olds, is I always take the clothes off. The more dressed they are, the more I'm taking the clothes off, just to make sure I don't miss something, because we do know that's an increasing trend in our population.
Awesome. Well, thank you, Amal and Ann. I asked you guys to do a little bit longer discussion of those 2 points, and that was just fantastic, the information you guys gave. So, Willie, we're going to speed things back up a little bit, make sure we get through everything here. I wanted to focus, I know we talked a lot about the history, but we really didn't talk too much. When you think about an exam on a pediatric patient who had a syncope episode, what are some of the things that you'd want to look for? And I'm happy to have you correlated back with this case, the fact that she did fall, which is also something that really didn't get explored too much further, didn't get explored, I'd probably say adequately, with this evaluation or with the first evaluation.
Yeah, I know with a fall, you want to consider any traumatic injury. There was, like what Amal and I both said, you want to check the abdomen, and then check for signs of a bruising. That would be, and especially with the low blood pressure there and looking gray. I think that would be kind of high up on my list too. Other things you want to consider, and in the evaluation, you want to check their skin turgor, the mucous membranes that can kind of reaffirm the signs of dehydration. Are they pale or pallorous? Cardiac and respiratory, obviously, tachycardic, low blood pressure. And then also the neurological exam can be a little more thorough. They can kind of cue you in or not if there's an intracranial process.
Awesome. Matt, we've talked a lot about, and we've sat here and sort of rubbed our chins for a long time. Let's actually do something. So you're at the bedside, and we recorded a podcast this morning, a In the Footsteps podcast. I put you at the bedside with our podcast this morning. I'm going to put you back here now. You're at the bedside. This is sort of what we got. Maybe we'll get more history later. What are you actually doing for this patient who is so profoundly hypotensive and tachycardic?
There's kind of 2 things. I want to figure out, why is their blood pressure low? Why is this patient in shock? And then I want to try to fix that. So just quickly, keep it simple. Why is the blood pressure low? Is it cardiogenic shock? There's nothing in this story. Ann said this. There's nothing to make me think this patient has a heart problem. Could they? Yes. Is it likely? No. Is it obstructive shock? Do they have a big saddle PE? There's nothing to make me think that other than this low blood pressure. So I would say, I've thought about it. I'm moving on quickly. Is it distributive shock? I mean, you're not going to show up for a hurdle race in septic shock. There's nothing to make me think this is an allergy. So no. So really everything's pointing to there's a volume problem with this patient. So my approach at the bedside, and what I just did is what I think. I'm a simple person. I think through these things. It takes 40 seconds. And I say, well, it must be something with volume. So I'm going to give them volume. I'm going to start pushing fluid as quickly as I can. You could squeeze the bag. I like the syringe, push the fluids in. You can press your bag, whatever. Just get this person volume. They clearly seem to need volume. And at the same time, I want to start looking for blood. That's my big branch point is, are they just dehydrated? They have bulimia, anorexia. Are we getting an inaccurate story about their intake, or have they had diarrhea they didn't tell us about? So, but that can happen. But I'm looking for blood. And the second I see blood or have a high suspicion there's blood where there shouldn't be blood. I'm going to switch from fluids to giving them blood. So quickly think, broad brushstrokes, why is this patient so shocky? And then you really kind of, when you're in that hypovolemic bucket, it's either fluids or blood.
So what we're going to do here is move forward, and as follows the book, we actually have decision point number 1, which is where we're at right here, right? And then, or I should say point number A, we're going to find out what happened to the patient, and then we're going to go back to our next decision point with our expert whisperers we have here. So you can see that she presented here. This is 5:23. It's not much later, 6:01. So a little over half an hour later, while waiting for the lab results, her mother takes her to the bathroom, interestingly, and she falls again, not surprisingly. And the mother yells out, quote, "My baby's not breathing," prompting a tech to call a code. She gets transferred onto a stretcher. She moans, "Ouch." So you do know that she's probably not in cardiac arrest. And the nurse says, "Well, I thought you didn't have any pain." And the patient says, "It's my belly." Okay. So I guess years and years of experience, and I won't add up all the years of experience on this call, Willie, you're not included in that, but probably over 100. And so maybe, Willie, you round us right up to 100, but those years of experience do help with that focus that everyone's been talking about with the abdomen. They lift her gown and they find a large bruise in the left upper quadrant. Her heart rate is now 168. Her blood pressure is not able to be auscultated. She's pale and lethargic. We are at decision point number 2. Willie, pretty brief softball question to you. Everyone gets one softball today. What's on your differential now, Willie?
I think it's pretty exclusively intra-abdominal hemorrhage. You could say with the location being in the spleen area, the splenic laceration, likely.
Okay, so that's fantastic. And we're putting you at the bedside now. And it's always this question between, clinical assessment and maybe clinical diagnosis and testing. So first of all, tell us where you and how you balance those two. And the next thing I would ask is, what are your thoughts on some further definitive diagnosis as far as what's actually going on?
I think one test that people underrate, I don't know if everybody has it, is the I-stat. And so sometimes I find people sending off labs for, everything from the emergency department goes stat, but the I-stat is actually a stat. So you can at least get an H&H to figure out which process you want to take. Because I agree with Matt, you have to know whether you're volume or you're blood, and you want to switch pretty quickly if you've got someone in that situation of being hypotensive. For an imaging choice, bedside ultrasound is incredible. We had a patient that was a trauma victim that went up to walk to the bathroom and actually had a syncopal episode in the bathroom, and the bedside ultrasound was positive on the fast. And I'll tell you what, it's again, like pregnancy, it's a yes, no question. You can also go down a little further after your fast and make sure you don't see a heartbeat, which is not a bad thing when you're in this kind of an acute situation. So I think that based on this patient being unstable, ultrasound, bedside ultrasound would be the way to get your quickest thing, because if you're positive, you might immediately be calling a surgeon, getting some resources available to yourself, or upgrading to a level 1 trauma or whatever resources you have available. As you all know, the stable patient will continue to be debated when you have used the bedside ultrasound. So if it's negative, it really doesn't help you, but a positive would be a huge, huge directional find for us.
So Matt, we're thinking about, the test we all love, the CT scan. I love it. I know I'm not supposed to love it, but I do. And if we're honest with ourselves, probably, but it's also been referred to as the donut of death. So how do you balance between, a little bit extending from what Ann said, ultrasound, consideration of CT? Is it ever okay to send a unstable patient to the CT scanner? Sometimes maybe we just need that diagnosis. Aortic dissection, just for example, we go with them. It takes like literally a minute and a half and we're back, but how about this specific patient? Extend a little bit what Ann had to say as far as us balancing risks and benefits of different imaging.
Yeah, Ann nailed it. I mean, a positive ultrasound, the specificity of an ultrasound is good. If you see something abnormal in this hypotensive patient, you're off to the races. You're calling surgery and all those things. I think the way to kill this kid is to trust a negative ultrasound. And I looked at the numbers, and if you get a negative bedside ultrasound, in my hands, these numbers are low, but in good hands, the numbers are 40 to 60% sensitive, which is flip a coin. Flip a coin in the room to decide, is this kid bleeding specifically from their spleen? Because Willie, you said it well. That's kind of what we're thinking, splenic area. So, do I like to send an unstable patient to CT? Absolutely not. Do I like to scan 12-year-olds? Absolutely not. This kid's going to die. They're not going to die from thyroid cancer from the radiation. They're not going to die because I'm going to go with them and try to keep them from dying. But the sensitivity of a CT scan is approaching 100. Nothing's 100, but you're in the mid 90s. So I think in this situation, I'm going to be very nervous going to CT because this is a crashing 12-year-old girl. But if I don't see something on bedside ultrasound that's clearly blood, I don't know what other way. I think we have to roll the dice, go to scan, and try to figure out, is this the spleen that's doing this?
And maybe yours is similar to ours. I'm sure that it is, but I mean, our CT scanner, I could walk there in probably 14 seconds. And, while you're doing all your stuff, you can do it sort of on the way. And CT scans are just so fast these days. So again, we're sort of balancing that out, the old donut of death. And I remember I said this is on one of our earlier bounce back book clubs in maybe 2022 even. And I said to Scott Weingart, this expression we always used to say about a tension pneumothorax seen on chest x-ray should be a mark of shame on the doctor that ordered it. And I'd been saying that for years. And Scott's like, they bring the x-ray machine to the patient now, and they don't have this like dripping black x-ray piece of plastic that you put up on this thing. And I thought to myself, it's like, well, that's true. With changing technology, sometimes we also change different practice patterns. But it gets us to Amal's question next is, and I think I know where you're going to go with this, because you are a clinical guy, and we have these vital signs, we have a gray color, we have this bruise, we have this history of a fall. Tell me where you go next. I had Matt take us, to the footsteps with therapy. Where are you going, Amal? Fluids, blood, calling surgeon. What are you doing? What do you do first?
Well, I think that's another softball for sure, that this patient definitely needs blood, uncross-matched blood immediately. Of course, it's going to probably depend on the emergency department and what type of hospital it is. If you work at a big hospital with a trauma center, you can probably get that blood a lot faster than if you're at a small community hospital. But fluids are not going to save this patient's life. She's losing blood, and blood needs to be replaced with blood as quickly as possible. So that's, I think I would go so far as to say that's a no-brainer. I want to push back just a little bit on the CAT scan being just 14 feet down the hall, because our CAT scan, and I know you're saying that just to make a point that you can get a CAT scan quickly, but in the real world, in the practical sense, if I wanted to get a CAT scan right now, we got to call radiology, make sure the tech is ready, there's no one else on the table, and then the nurse is going to get the monitor, put it on the stretcher, get everything together, go down the hall to radiology, take the monitor off, get the patient onto, so all of this stuff actually takes more than just a couple of minutes. So, I think that the safest place for this patient is in the emergency department with all of your equipment in your cocoon. And even if the CAT scan is right across the hall, it's not as quick as it seems. And even in our place which is a trauma center, and we have fellows and consultants for everything. Stuff takes time, but this patient needs blood right away.
Well, I guess whenever you're thinking about the more serious diagnosis, right, you say to yourself, okay, let's just clinically diagnose her with a splenic rupture or laceration or whatever it might happen to be, splenic bleed, and we'll just treat her as if. We'll get the surgeon involved, and they'll say, what does a CAT scan show? And we'll say, dude, don't have one, or whoever is answering, right? Not that they're a dude necessarily, but look, that's my clinical diagnosis. If you need a radiologic diagnosis, we can do it. Maybe we get the blood going at first, get things stabilized a little bit more. But it seems like that's sort of where we're going here. I mean, this patient might have have had just coded, or maybe they just didn't check the pulse correctly. It was really, really sort of weak. So let's move on next. And in fact, to tell the truth, Willie and Ann, any thoughts on the blood question? And then Matt, hey, I don't want to jump past things too quick. I think there's time for a rebuttal.
From my standpoint, getting uncross-matched blood, as you talked about the CAT scan, is going to take me some time. So I think IV access is going to be challenging. I'm 11-year-old at least, but once you're hypotensive, everything blooming collapses. So considering IO access, to have a place to give it would be there. I'd still start with normal saline just to try and build the pressure up until I could get blood products. It would probably take 5 to 10 minutes, maybe 15. I think ours is 15 minutes. But at the same time, if I can get her systolic up a little bit, that may help with the airway issue, depending on which direction we're going to go, because to do an RSI with a hypotensive patient is just never desirable. If you know what you all agree with me, I'm sure. But blood,
Yeah,
I would say
absolutely.
cross-matched as soon as possible.
Yeah, Alan Hefner had some pretty surprising statistics on intubating hypotensive patients, as well as, peri-intubation arrest and the incredibly high mortality from that. Willie, any thoughts? And then Matt, be interested in your thoughts based on what other people had to say. We'll get this party started.
Yeah,
Willie,
I think I agree with Ann is this getting in some just fluid in general until the blood comes, but I agree with everyone. Obviously, I'm not a ER physician and I don't see this a whole lot, so that's just kind of my 2 cents.
got it. Any further thoughts, Matt?
No, I mean, I have a 13-year-old daughter. You could put Dr. Pepper into her circulating volume and she would stay alive for about 45 minutes to get the scan. So, yeah, academically, should we get to blood as quick as possible? Yes. We've all worked in shops where that's impossible or impractical. So yeah, don't let perfect be the enemy of good in this patient. Fluids are fine. She needs volume.
Awesome.
And
All right.
Matt, one thing I'll say is I agreed with you with pushing the fluids. Like this is one time I would put a syringe on the end and start pushing in the manner you described.
All right. So what happens with the patient? Surgery is called, the intern arrives, and the patient now has become less responsive again. And at this point, she does actually go into cardiac arrest and they cannot get a pulse. So they start chest compressions. The mother is obviously distraught. And so we are now at our next decision point. So, and unfortunately, despite all of our best efforts, fluids, ordering blood, thinking about all this kind of stuff, this pediatric patient, 12-year-old girl who was running a race literally hours ago, is now in cardiac arrest. What are some of your initial steps in this patient with cardiac arrest?
Boy, this would be a tough one. This would be a very tough one because you're going to do your ABCs like all of us would, where you continue doing your resuscitation, trying to get the blood products. You're going to have to secure the airway. The question is going to be how quickly you can get a surgeon to you, or you can get them. Although in this situation, I'm not sure what they would even do. We just don't have a lot of good things with thoracotomies in pediatrics. And so I think this would be a very difficult situation to be in. I would hope with the blood transfusion, I would make sure. There have been a couple of studies in peds showing that we don't do very well with picking up on pulses. So I would make sure we had ultrasound and made sure we checked for cardiac activity and made sure we checked the pulses with Doppler, just to make sure that we were actually in a cardiac arrest situation. And I've seen several where the patient did have a pulse. You still were in a bad place, but not as bad as full arrest. And you would obviously start compressions and do all the usual basic type things. And I can't think of anything special that would reverse this situation.
So, Amal, you work in a big trauma center. You have a lot of residents. Let's put you in a smaller ED. You're the lone doc. It's 3:00 in the morning. You have this patient in cardiac arrest. You can only do what you can do, right? let's just talk about the airway specifically. Should she be intubated? Is that the first thing you're going to look towards, or is bagging initially adequate?
Well, I hope I've got at least a couple of staff with me. So a nurse,
It's
a
not just
tech,
you. You have nurses and techs and all,
housekeeping. I mean, I'll take anybody at this point, right? Um, well, first, you're going to start bagging, of course. If the patient's not breathing, I think the first step is bagging, and we'll get her on the monitor as quickly as possible, assuming she's not on the monitor yet. And the first thing I want to see is what the rhythm is, because the only way I'm not heading immediately towards some type of a definitive airway is if she's in VFib. I don't know why she would be, but if you see VFib, then the immediate priority is to shock, to defibrillate as quickly as possible. I'm going to be hoping for all the world that this isn't asystole, but this is perhaps PEA. And maybe the reason there's no pulse is just that she's so hypotensive that you don't feel a pulse. And maybe as the blood goes in, we're going to get a pulse back, and maybe there's a shot there. But these things are happening simultaneously. If there's no pulse and it's not VFib, then somebody's going to be starting compressions. Meanwhile, we're bagging while getting everything together for a definitive airway. So unlike the boards, which says what is the immediate next thing you want, there's things that are happening simultaneously. But the only way I'm not heading in the direction of definitive airway quickly is if the patient's got VFib, in which case, and we're heading to defibrillation. Otherwise, compressions while heading towards airway, and hopefully that blood's heading in as quickly as possible.
So this was a study that came out like literally, well, it's the 20th and today is the 1st. So literally 11 days ago in JAMA Network Open. And this sort of similar to a lot of previous studies, including one by Marianne Gachet-Hill, who I think a lot of the folks on this call know, who looked at intubation versus bagging pre-hospital for EMS. But at any rate, look, there's always that risk aspiration, all that kind of thing. But in general, most of our patients, we can just start with bagging. And sometimes it really is just a short period of time before we do get them back with some chest compressions or shock or whatever it might happen to be. So I thought this was interesting that this study came out so recently. Willie, let me have you give a short answer to this one. And Matt, I'm going to do the same thing so we can have everyone have opportunity to give their take-home points as we are at 8:53. So Willie, the physical exam, how helpful can that be with a patient who has had a trauma? What are some of the things that we might see? And I'll just sort of start us off with one thing is hemotympanum. That wasn't present with our patient, but what are some of the things that we might be able to see on exam that aren't necessarily apparent from across the room?
So you mean like things you have to look like specifically look for on exam?
Yeah. So say you undress the patient and are taking a look. I mean, with this patient, there's one thing on her abdomen exam too.
Right. Yeah, like undressing the patient, checking all the skin. If you suspect head trauma, checking for pneumotemp or hemotemp, blood behind the eardrum. Bruising otherwise, pallor on the mucous membranes. Pupils, if there's pupils are equally and they're reactive. But yeah, generally speaking, not going to be super helpful unless you do all
and
the
this might
specific
be just
things.
like you're saying, Willie, a time that you want to do a really good and more thorough exam on a patient who you're able to see for, I might even just add a few other things in, like, a battle sign or, it's uncommon, but, colon or grade Turner, like all those sort of things, palpating posterior cervical spine. So I think someone talked earlier about this across the room neuro exam. Well, you can't really do an across the room trauma exam. So Matt, I'm going to take us all the way back to the beginning here. Tell us with this very first visit, maybe, or I should say maybe at the beginning of the second visit, what are some of the things that could have been done differently that might have changed the way that this whole thing progressed?
It's a weird case. We all agree the initial assessment documentation is not good. That being said, a 12-year-old kid can tell you things. And I would expect if a 12-year-old kid had blood in their belly, they might mention that their stomach hurts. I mean, maybe I'm projecting. My children tell me every ache and pain, but I think if you examine the belly, I would expect that it would hurt. And if this kid is a 2-year-old can't tell me, but it is, the weirdness for me is that they have a splenic injury and have no symptoms related to that other than the secondary stuff of, I'm going to try to die pretty quickly from this asymptomatic abdominal catastrophe. So it's easy to say I would have examined the belly. I push on most or all patients' bellies, but I think that to me is the only piece, other than doing a better job overall of having a systematic approach. I don't see an abdominal exam on that first visit.
All right, so here's what we're going to do. Well, actually, I'll just pull us a little bit to the very end, is that she ended up going to surgery and she ended up walking out of the hospital and she ended up doing just fine. So the care that the 4 of you have done saved her life. Congratulations. You guys did a great job. But in all seriousness, this is a true case. And this actually happened. And sometimes when you think about some medical legal issues, or most importantly, patient safety issues, it's a matter of failure to diagnose, but sometimes it's that timeliness of diagnosis. And as I told the story in the beginning, she did fall into this hurdle and she had this dizziness. She came in and that really wasn't adequately explored. And I get it that we're all sitting here in the comfort of our own homes and not seeing 15 other patients at the same time. So why don't we wrap this thing up? Matt, we'll start with you. We'll just go in alphabetical order. While we're doing that, I'm going to flash up the QR code so folks can get their free CME. But Matt, if you could just bring us home 30 seconds that you'd like folks, of some things that you'd like folks to take home after spending the last hour with us.
My big takeaway, and it took me a couple of years of practice to realize this, is that the patient that you think is fine, that you're going to send home and do minimal testing on, this patient, I actually chart more on that patient than the 64-year-old chest pain, a high heart score, I'm going to admit them for a rule out. You get so much credit, and I think our patient outcomes are better for just thinking through it as you write the chart. Use macros, use scribes, use AI, but actually put thought into this, I think you're fine patient, rather than focusing on I'm going to admit them to hospitalist.
Awesome. All right, Anne, 30 seconds for what you want folks to take home.
I agree with Matt. It's the well patients, or the patients you think are well, or you think you know the answer, that are the higher risk ones that you want to be more careful with. But I would say what you said to me years ago, Mike, vital signs are vital. If you have abnormal vital signs in a pediatric patient, recheck them. If they're back to normal, fever's down, everything looks great, you're in a good place. If they're still bad, there's something wrong, and it's your job to figure it out. And so don't just blow them off and say, oh, I think that was just triage. Get a second set of vital signs, get a third set of vital signs. And if things aren't going the way you expect, then go back in and get a better history.
Amal, 30 seconds of takeaway points.
I'm not sure I have a whole lot to add to what Matt and Ann said. I mean, vital signs are really important. And you've got to do a good history. You've got to do a good physical. You've got to document it. And you can always argue that maybe they did a great history and physical and they just didn't document it. And she had nothing. But you can't argue with abnormal vitals. No one's going to believe you. So those have to be addressed.
Awesome. Willie, a couple take-home points?
Yeah, I would kind of third that, the vitals thing. I feel like there's been, just in my limited career so far, just residency and fellowship, there's been a handful of times where it's just one thing that kind of sticks out. And it might seem peculiar at the time, might not fit what you're thinking. And if you just, recheck it, it should reaffirm it's that, that's abnormal. And then you should kind of go down that rabbit hole, even when everything else seems okay. Because you never know, it could kind of balloon up and be a lot worse. You'd be a lot more stressed, kind of pick it up, trying to figure out what's going on when everything, crap's hitting the fan.
Awesome. And I'll just throw in a couple points of my own. The first is evaluating each of the complaints and each of the things on the problem list. In this case, patient had lightheadedness, but she also had a fall. And I think about the game-changing question. Sometimes patient with headache, carbon monoxide, just for example, others in the home, are they ill? Do you have a carbon monoxide detector? Are you heating your trailer with a kerosene lamp, right? So that's that one question, one potentially game-changing question that could change the whole outcome with whatever that answer might happen to be. And there's a lot of those game-changing questions. In this case, some of those game-changing questions were related to this sort of ill-defined trauma. Even when she came back and she looked so bad, well, having that information, why did it have to be after she had that second syncopal episode when she went to the bathroom, that it was at that point they pulled up the gown and saw that large bruise over the spleen. Thank you, everyone, for giving us 1 hour of your time tonight. Thank you, especially to our panelists. And man, I can tell you, this has been one of the funnest, and I'm glad it is because it is our last of the Bouncebacks Critical Care Book Club. For folks who want to sign up for the next one, it will be on Monday, February 2nd. So the first Monday in February. We're going to skip January. And we are going to have that link up on the Bouncebacks website. That's the one on the top there, embouncebacks.com. I will have that up by tomorrow afternoon at the latest. So we hope to see other folks there. And again, thank you everyone so much for sharing your time with us. And I think I can say from Columbus, Ohio, go Bucks. Good night,
Why
everybody.
you?